Good morning. I am Dr. Sudipta from Tata Medical Center, Calcutta. Today, my topic of presentation is Rapid Diagnosis of Carbapenem Resistance, Experience of a Tertiary Care Cancer Institute with Multiplex PCR. In the present scenario, sepsis because of multi-drug resistant organism is a worldwide challenge, and studies have shown that in coming years, a huge amount of financial resources will be spent to control and treat this infection. Though virulence and resistance does not go hand by hand, some of these MDRO bugs are highly virulent, like Klebsiella pneumoniae. Inappropriate empirical antibiotic in these patients lead to poor outcome during sepsis with these MDRO bugs. And efforts has been made to anticipate the risk of multi-drug resistant organism in sick patients. There are multiple literatures that has identified risk factors like colonization at any sites by carbapenem resistant Klebsiella, length of hospital stay before ICU admission, previous antibiotic therapy, previous invasive procedures, old age, and poor functional status. But it is very difficult to apply in institutions like us, where patients are getting admitted very frequently because of either cancer treatment or because of its complication and have been colonized with multi-drug resistant organisms. Frequent reports suggestive of community-acquired multi-drug resistant sepsis is also there. So it is very difficult to choose empirical antibiotic in this scenario. Kumar et al. Has shown that with every hour delay in giving appropriate antibiotic in septic shock patient, mortality increases significantly by 7.6% per hour, and it is a significant number. Recently, GPT steering committee in their study has found that only 10 out of 152 carbapenem resistant Klebsiella were treated empirically with at least one effective antibiotic, leading to significant high mortality among the rest. A recent meta-analysis focusing on mortality attributable to carbapenem-resistant Enterobacteriaceae, in which 8 out of 9 studies dealt with carbapenem-resistant Klebsiella infection, reported a relative risk of death of 2.05 times compared to carbapenem-susceptible gene. So, all recommendations are now in favor of giving broad-spectrum empirical antibiotic in septic sick patients. But there is a flip side of this. This empiric broad-spectrum antibiotic practice leads to increasing trend of MDR infection in the community. So, stringent use of antibiotic stewardship program is the need of the hour, and early de-escalation to targeted antibiotic therapy is now a recommended practice. From that aspect, resistant pattern of the bacteria become more important than the bacteria itself. During conventional culture sensitivity method, appropriate volume of blood is being inoculated in culture bottle. Once the culture bottle flags positive, sample from culture bottle is subcultured into solid media to have a pure colony. Then that bacterial sample was being introduced to Vitek2 system to check for sensitivity. This is the gold standard technique, but time consuming, requiring at least 2 to 3 days after blood culture become positive. On the other hand, direct sensitivity can be checked from blood culture positive bottle by directly introducing the positive sample into the Vitek2 system. Though it is less time consuming than the conventional technique, still it will require 1 to 2 days. Besides, it will be difficult to interpret if there is a mixed growth. Most common cause of carbapenem resistance is carbapenemase production by carbagene. As per AMBER classification, they has been subgrouped into A, B, and D. Other mechanism of resistance is outer membrane permeability defect because of porins, and it is more common with Pseudomonas. In our hospital, 30 to 50% of Enterobacteriaceae are carbapenem resistant as per Vitek2 method, but clinical failure is much more than that. Data from Tata Medical Center in the year 2017-18 has shown that 36% of our Enterobacteriaceae are meropenem resistant. Among the Enterobacteriaceae, Klebsiella has a much higher incidence of resistance, that is 53%, compared to E. coli, which has only 21%. 35% of the lactose non-fermenter are meropenem resistant. And on comparative analysis, Acinetobacter has much higher resistance, that is 62%, compared to Pseudomonas, that has 23% of meropenem resistance. Now, if you look at the cause of clinical failure, there may be unknown level of carbapenemase production at the site of infection. While treating the sensitive one, we may select out resistant strains. Additional mechanism of carbapenem resistance, that is ESBL producer with porine abnormality, may be a cause. Low carbapenemase producing bug may be there with carbapenem sensitivity in the susceptible range. There can be a potential carbapenemase producer without any clinical expression, that is, heterogeneous expression of resistance. Early diagnosis is the key for carbapenem resistant infection. There are different phenotypic methods to diagnose carbapenem resistance. Modified host test is the most popular one. It can diagnose KPC and OXA48 but lacks sensitivity and specificity. Combined this test with boronic acid and EDTA can diagnose KPC and MBL respectively. E-test MBL strip is also available. Spectrophotometric assay can diagnose carbapenem resistance but cannot identify the type. So overall, this type of test is growth dependent. Overall turnaround time is 80 to 24 hours. Results are to some extent subjective, and most of them can't diagnose OXA48. So these tests are not much clinically helpful. There are other rapid diagnostic tests available in the market. Accelerated diagnostic method is a non-nucleic acid test that evaluates the response of bacteria in positive blood culture broth to carbapenem antibiotics by automated microscopy. This method requires around 5 hours to perform. Another option is multiplex. Here the organism is incubated with a carbapenem typically for 2 to 4 hours. The mass-based detection of carbapenem and its degradation product can be done with this technique. Here, hydrolysis of carbapenem beta-lactam rings results in a measurable mass increase that can be differentiated from the native carbapenem mass on multiplex machine. On the other hand, the use of this machine can predict carbapenem susceptibility in a different way by comparing peptide mass, which is a correlate of microbial growth in presence or absence of meropenem. Another option for rapid diagnosis is polymerase chain reaction. There are certain advantages of PCR, like it has short turnaround time. Small subgroup of CRE can be identified with this technique. Even the dormant one with a potential for express carbapenemase gene can be identified. Identification of specific carbapenemase gene is also necessary because of development of targeted antibiotic therapy. For example, ceftazidime avibactam is active against KPC and OXA, whereas aztreonam is active against MDM. So, knowledge of carbapenemase gene is important for use of these cholesterol-sparing drugs. There are some PCR-based diagnostic tests available at this moment, like film arrest test, Virigin test, gene expert Carba test, etc. Most of them have some limitation, like film arrest test has poor sensitivity, Virigin test cannot diagnose OXA23, which is a variant of OXA48, and gene expert test Carba has low positive predictive value for some specific target. Richard et al. Has compared KPC real-time PCR with meropenem-imipenem automated susceptibility testing and ertapenem drift diffusion susceptibility testing and found good sensitivity and specificity. And using real-time PCR, the time from identification of a positive blood culture bottle to determining carbapenem resistance can be reliably reduced from greater than 48 hours to approximately 3 hours in this study. Verad et al. Had evaluated PCR-based testing for surveillance of KPC producing CRE, and they also found good correlation between microbiological and molecular data. But time to both a positive and a negative result was significantly shorter for PCR-based assay than the culture. Rachna et al. Has compared multiplex PCR with routine laboratory phenotypic methods, and they found that PCR has much better sensitivity and specificity compared to tests like modified Hodge test. Now, if you look at the data from Tata Medical Center, Calcutta, we have analyzed last 1 year data. Number of samples processed was 392. The blood culture system we are using is automated bacterial machine. The PCR technique has been developed in-house by our scientific officer and a microbiology team and has been validated. Gene we are presently detected are NDM, NDM1, KPC, OXA48, OXA23 and VIM. Antibiotic sensitivity was tested by Vitek2 machine, and once the blood culture is positive, multiplex PCR report is usually available by 3 to 4 hours. Direct sensitivity results are available by 24 to 48 hours, and the final culture sensitivity result is usually available by 48 to 72 hours. On the other hand, if the carbapenem resistance can be again tested from isolated colonies if the correlation of preliminary results do not match with the final Vitek2 base report. In our study, among the PCR positive results, if we compare that with Vitek to final culture sensitivity report, the sensitivity is around 99.3%, specificity 94.65%, positive predictive value 93.1%, and negative predictive value is around 99.43%. Most common carbapenem resistant gene in our hospital is OXA48, which is around 43%, followed by NDM1, which is around 25%. About 20% of the cases, there is a combination of two carbapenem resistant gene expression like KPC plus VIM or NDM plus OXA. Among 177 PCR negative sample, Vitek 2 had shown carbapenem sensitive except one sample. One sample of Acinetobacter, which was PCR negative, had finally leads into carbapenem resistant by Vitek. There are some limitations of PCR based technique like cost, training, manpower, and infrastructure. Some selective genes can be evaluated by this technique, so resistance due to other gene or other mechanism can be missed, and the interpretation of the result to be done as per clinical context. So, this technique is best suited to rule in as opposed to rule out infection with a CRE. So, to conclude, MDRO is a challenge in our daily sepsis management. Conventional culture sensitivity technique is still the gold standard. Real-time PCR for carbapenemase gene can help us for early diagnosis of carbapenem resistance and will guide to choose or to modify antibiotics accordingly. It is more practical to rule in infection rather than rule out by using this technique. And with this knowledge of carbapenem resistant gene, we can modify our targeted antibiotic therapy as a colistin sparing agent. These are my references. Thank you.